You know that feeling, right? That moment, a thought just lands in your head. Maybe it's like a really harsh judgment about yourself or this sudden spike of worry about something.
Yeah, happens all the time.
And it just feels completely undeniably true for a second. Even if, part of you suspects it might not be quite right.
Like it bypasses logic.
Exactly. It's like your mind's on this weird autopilot and, well, it often seems to veer towards the negative.
That exact experience you're describing, feeling sort of swept away by those automatic, uninvited thoughts.
Yeah.
Well, that is precisely the territory we're getting into today. Because the source material for this deep dive really lays it out clearly.
Okay.
There's structured, actually evidence-based way to understand why those thoughts feel so powerful. And maybe more importantly, how you can actively work with them.
Absolutely. Welcome, everyone, to a deep dive into cognitive behavior therapy, or, well, CBT, as most people know it. And if there's one core idea this material really hammers home, it's that super powerful dynamic link between what we think, how we feel, and then what we actually do.
They're constantly feeding each other.
Totally interconnected.
And our guide for digging into this, it's a pretty comprehensive set of source materials. It doesn't just define CBT.
Right.
It traces its history, lays out the foundational model, and really details the practical techniques used to help people, get a handle on these internal patterns.
So our mission, really, is to pull out the key insights, the most practical stuff from this material.
The essentials.
Yeah, we want you to walk away understanding not just the theory behind CBT, but how it actually functions day to day, from its kind of surprising origins right through to how it gives people skills to reshape their thinking and behavior for good.
Think of it like we're extracting the roadmap directly from the source for you.
Exactly.
We're pulling out that core wisdom embedded in the text, giving you the context and the deeper understanding to really grasp not just the individual pieces of CBT, but how they all fit together into this, pretty powerful approach for making changes.
Okay, let's unpack this then. To really get CBT, we kind of need to know where it came from.
Yeah, the history is important.
And the source material points to a really fascinating origin story. It starts back in the, late 1950s, early 60s, with Dr. Aaron Beck's research.
Right, and interestingly, he wasn't actually setting out to invent some whole new therapy. Not at all.
No.
He was initially trying to validate a key psychoanalytic idea about depression.
Okay, which idea with that?
Well, the prevailing psychoanalytic theory back then often suggested that depression was basically hostility or anger turned inwards against the self.
Ah, okay. I've heard that.
So Beck's hypothesis was, logically, that depressed patients' dreams would be just full of themes of aggression, hostility.
Makes sense based on the theory.
But the source details how when he actually collected the data, when he looked at their dreams, he found the complete opposite. Yeah. Depressed patients had fewer hostile themes in their dreams. And instead, surprisingly, there was this huge prevalence of themes about being defective or deprived or experiencing loss, personal loss.
Wow. So the data just didn't fit the theory at all.
Not even close. And this unexpected finding, it was a really pivotal moment.
Yeah.
It fundamentally challenged that whole hostility turned inward idea.
Right.
And it pointed towards something completely different being at the root of depression.
Which was?
The patient's own negative interpretations, their perceptions of themselves, their experiences, their future. As the material describes it, this was like a key piece of the puzzle just clicking into place. It led him to question other core psychoanalytic concepts too, and start looking for a new way, a different framework to understand psychological distress.
Which brings us pretty much directly to the heart of what this material presents as the core principle of CBT.
The cognitive model.
The cognitive model, exactly. It's this idea that our thoughts, our interpretations, they aren't just passive bystanders.
No, they're active players.
They're the crucial link, the thing that determines how we feel and how we behave in response to whatever situation we're in.
Precisely. The model isn't saying, that situations directly cause our feelings, like A causes C.
Right.
Instead, a situation happens that's A, it triggers thoughts or interpretations about that situation that's B, and those thoughts, the B part, are what primarily drive our emotional and behavioral reactions, C.
ABC. Situation, thought, consequence.
You got it. And often these thoughts, these Bs, they aren't these deep, conscious, well-considered analyses.
No, they're quick.
Super quick. Automatic, even.
Ah, automatic thoughts. Okay, yeah, the source material puts a lot of focus on those.
Definitely.
They're those, like, rapid-fire thoughts, or sometimes even images that just seem to pop into our heads, right?
Yeah.
Without us consciously trying to think them.
Yes, exactly. They're often really fleeting. Sometimes it's just a few words, like a headline, or maybe a quick mental snapshot.
Like, you get a critical email.
Yeah, good example. Your automatic thought might just be, bang, I always mess things up. Or maybe you see a quick image of yourself failing at the task.
Okay.
The key insight here, and the source really highlighted this, is that these automatic thoughts, they feel incredibly real and true in that instant.
But really convincing.
But they're often distorted or inaccurate, or just one possible way of looking at things.
Okay, but where do they actually come from? It feels like they appear out of nowhere, but the material says they stem from something deeper, right?
Exactly right. They aren't random. Below the surface of those immediate automatic thoughts, there are more enduring ways we think. Cognitive structures, beliefs. These are fundamental ideas people hold about themselves, about other people, about the world in general, and they develop over time, usually from early experiences.
And the most fundamental of these are called?
Core beliefs.
Core beliefs. So like that really deep-seated conviction that maybe you're inherently flawed or incompetent or maybe unlovable, things like that.
Those are classic examples, yes. These core beliefs are often so deeply ingrained, so fundamental to how someone sees everything, that they feel like absolute truths. They're often not even articulated consciously because they're just taken as, well, reality.
Just the way things are.
Yeah. The source gives an example.
Yeah.
Someone's reading some challenging material. The automatic thought might be, ugh, I'm too dumb for this.
Okay.
That thought might stem directly from an underlying core belief like, I am incompetent.
Got it. And then layered on top of those core beliefs, you have intermediate beliefs. Is that right?
Yes, that's the next layer up, so to speak. These are things like attitudes, rules, assumptions that kind of logically follow from the core beliefs.
Okay, so give me an example. Sticking with, I am incompetent.
Okay, so if the core belief is, I am incompetent, an intermediate belief might be a rule like, if something looks difficult, I should just give up immediately.
Right, because trying is pointless if you're incompetent.
Or an assumption like, if I try really hard at something, I'll probably still fail anyway.
Yeah, I see. So the core belief is like the bedrock, the foundation. The intermediate beliefs are the sort of rules for living, the strategies you build based on that bedrock.
Yeah, the if-ands and the shoulds.
And then the automatic thoughts are like the in-the-moment applications of those rules when you hit a specific situation.
You've nailed it. That's the hierarchy.
In understanding your unique structure, mapping all this out for an individual, that's what the source calls cognitive conceptualization. And that's a key task in therapy.
Absolutely. Yeah. It's like building a personalized map of your mind's operating system, how your thoughts and beliefs connect and influence your feelings and actions.
And the therapist starts figuring this out early on.
Yeah, the therapist starts forming hypotheses about this conceptualization pretty much from the get-go. Gathering information, session by session, talking with the patient, and continuously refining that map collaboratively with the patient. It's not like a static diagnosis the therapist just hands down.
No, it's dynamic.
Very dynamic. It's a shared understanding that evolves over time, focusing on the patient's specific cognitive patterns.
Okay, so we've got the basic model. Situation, thought, feeling, behavioral.
Check.
We know thoughts can be automatic, popping up quickly, and they often stem from these deeper, intermediate, and core beliefs.
Check again.
So the big question now, and this is where the source really dives into the practical stuff, is how do you actually work with these? How do you start to, like, adjust that internal autopilot?
Right. How do you intervene? That's where the techniques come in.
Okay.
And while cognitive techniques, especially learning to evaluate those automatic thoughts, are really central, the material is also clear that behavioral strategies and problem solving are often just as essential.
So it's not just thinking about thinking.
Not at all.
Yeah.
The specific mix of techniques depends on that cognitive conceptualization we just talked about. What's the main issue? What beliefs are driving the problem? What behaviors are keeping it going?
Okay. And when it comes to evaluating those automatic thoughts, the source talks a lot about Socratic questioning. It's not about just arguing with the thought, is it? Like telling yourself, that's stupid.
No, definitely not. That usually doesn't work very well anyway.
Yeah.
Socratic questioning is more like guided discovery.
Guided discovery.
Yeah. Think of it like being a detective calmly examining the evidence. The therapist, using carefully chosen questions, helps the patient become their own detective about their thoughts.
So questions like,
okay, what's the actual evidence that supports this thought? And just as importantly, what's the evidence against this thought?
Okay, so if someone has the thought, I'm definitely going to mess up this presentation tomorrow,
Right.
the therapist wouldn't just say, no, you'll be fine.
No. They might ask, okay, let's look at that. What concrete evidence do you have that suggests you will mess it up? And then, okay, now what evidence is there that you won't mess it up? Have you handled similar situations okay in the past? What skills do you have?
So it's about helping the person weigh the evidence objectively for themselves.
Exactly. Helping them arrive at a more balanced, more realistic perspective based on the facts, not just the feeling.
Makes sense.
Other questions might explore, are there alternative ways to explain this situation? What are the real consequences of believing this thought versus not believing it? Or considering the best, worst, and actually most realistic possible outcomes.
And spotting patterns too, right? Like those cognitive distortions the source mentions?
Yes. Identifying common thinking traps things like catastrophizing, where you assume the worst will happen, or mind reading, assuming you know what others think negatively about you. That's also part of this evaluation process. Naming the distortion can take away some of its power.
So the big insight here is that just the act of examining the thought, applying some critical thinking to it like you would to any other claim, can often reveal that it's maybe not as solid or universally true as it felt just a moment before.
Precisely. It creates distance. It creates perspective. It helps you see it as a thought, not a fact.
But as you said, sometimes just thinking about the thoughts isn't quite enough.
Right. The source notes that especially when certain behaviors are a really big part of the cycle, like with depression or anxiety, you need to address the behavior directly too.
Which is where behavioral techniques come in.
Exactly. And the material talks quite a bit about behavioral activation, especially for depression.
Yeah, tell us about that.
Okay, so behavioral activation is absolutely vital for depression. When someone's depressed, they often feel this profound lack of energy, zero motivation.
Yeah, everything feels pointless.
Right. And they predict they won't enjoy anything, even things they used to love. So what happens?
They stop doing things, withdraw.
Exactly. They withdraw, become inactive, and that inactivity, it just feeds the low mood. It reinforces those negative thoughts like, I'm useless or nothing matters. It's a vicious cycle.
Okay, so behavioral activation tries to break that cycle.
Precisely. The technique involves intentionally scheduling activities, often things that might bring even a little pleasure or a sense of accomplishment or mastery, even when you absolutely do not feel like doing them.
You do it anyway.
You do it anyway. It's scheduled. And then this is key. As the source describes, you track your actual experience. How much pleasure did you really get? How much mastery did you actually feel? Even on a simple 0-10 scale.
So you gather data.
You gather data. The insight here is powerful.
Yeah.
You don't have to wait until you feel motivated or happy to take action. Acting first can actually change your mood.
Wow.
And it provides concrete, real-world evidence that directly challenges those negative predictions like, I won't enjoy this or I can't do anything.
Doing the thing provides the data to counter the thought. That is powerful.
It really is. And it's not just activation. The source mentions other things too, like problem-solving skills training.
Right.
Helping patients tackle practical difficulties that might be contributing to their distress. Or other specific skills training, maybe assertiveness or communication skills.
Which, again, provides evidence against negative beliefs like, I can't handle things.
Exactly. And a big one is addressing avoidance behaviors.
Avoidance.
Yeah, those things people do or don't do to avoid feeling anxious or uncomfortable. They often feel like safety behaviors.
Okay. Like avoiding social situations if you have social anxiety.
Perfect example. That avoidance gives temporary relief from the anxiety, sure. But the source points out it also prevents the person from ever learning that the feared outcome might not happen, or, critically, that they could actually cope, even if it did.
So avoidance keeps the fear alive.
It reinforces it. So therapy often involves gradually facing those avoided situations.
Okay. Now, the material also mentioned that automatic thoughts aren't always words. They can be images, too.
Yes, absolutely. Images can be incredibly potent, sometimes even more distressing than verbal thoughts.
So how do you work with those? You can't really question an image in the same way.
True. The approach is a bit different. The source outlines several techniques specifically for images. One is called following the image to completion. So if the automatic image is, say, of some feared event starting to happen.
Like tripping during the presentation.
Yeah. Instead of pushing the image away, you intentionally follow it through in your imagination. What realistically happens next? And next. Often, when you follow it to a realistic conclusion.
It's not as bad as the initial flash.
Often, yes.
Yeah.
It leads to a less catastrophic outcome, or maybe even an outcome you realize you could handle. You see yourself coping within the image.
Ah, so you push past that initial terrifying snapshot.
You see it through. Or another technique is to practice inserting coping strategies into the image itself while it's happening.
Okay.
Other methods involve things like deliberately substituting a more realistic or adaptive image, or using techniques like repeating the image quickly or imagining it on a screen far away to kind of lessen its emotional punch.
Interesting.
The source even discusses using imagery techniques to reprocess difficult early memories, ones that might be strongly linked to those core beliefs we talked about.
It really sounds like a very active, engaged process, both inside the therapy session and, crucially, outside of it.
Oh, absolutely.
The source material places a huge emphasis on homework, or as it's sometimes called, self-help activities or action plans.
Homework is critical. Non-negotiable, really, for effective CBT.
Why so crucial?
Well, think about it. Therapy sessions are maybe an hour a week. Real life is the other 167 hours.
Good point.
Real, lasting change happens through consistent practice and application in your actual daily life. Homework is how patients take the skills they're learning in session and apply them, how they test out those negative thoughts and beliefs in real-world situations, how they generalize their progress beyond the therapy room.
So it's things like keeping those thought records we talked about to practice evaluating automatic thoughts.
Exactly. Or scheduling and then tracking those behavioral activation activities. Or practicing new communication skills you discussed. Things like that.
Makes sense.
The source actually calls homework a no-lose proposition, which I think is a great way to frame it.
How so?
Because even if a patient struggles with the homework or maybe doesn't complete it, that experience itself provides incredibly valuable information.
Data again.
Yes. It's data to discuss in the next session. It helps identify barriers. Maybe an underlying belief got triggered. Maybe the assignment was too hard. It helps refine the techniques and understand the patient's challenges more deeply.
So it's not about passing or failing the homework.
Not at all. Therapists anticipate difficulties. They usually start with easier assignments and build up gradually. The goal is learning and trying.
It really does sound like learning a skill set. And, well, any skill requires practice to actually stick.
And perseverance, definitely. Now, while all these techniques are kind of the engine of change in CBT, the source material is also very clear that the therapeutic relationship, the connection between the therapist and patient, is the absolutely essential container for all this work.
The foundation.
Yes. It's described as collaborative, yes, and structured, but fundamentally it has to be built on trust, empathy, and genuineness from the therapist.
Just being a nice human being in the room, as the source puts it, that's foundational.
It really is. Treating the patient with basic respect and understanding. That connection, that alliance, is what allows the patient to feel safe enough to actually explore these often difficult, vulnerable thoughts and feelings.
Makes sense.
The therapist demonstrates they understand by listening carefully, asking thoughtful questions, reflecting back what they hear, and importantly, they consistently seek feedback from the patient.
Feedback? Like how?
Directly asking things like, how did you feel about our session today? Or did that explanation make sense? Or did that technique feel helpful or maybe off track? Checking in both verbally and by reading nonverbal cues.
So a real partnership.
Absolutely. And the source points out, interestingly, that this alliance often tends to get even stronger as the patient starts to feel better and see progress.
Which makes a lot of sense, right? You trust the process more.
It's a positive feedback loop. A strong alliance means the therapist and patient are truly functioning as a team, working towards the same goals. And sometimes, the relationship itself can even become part of the therapy, constructively.
How do you mean?
Well, if a patient has, say, distorted beliefs about relationships like people will always reject me, those beliefs might start showing up in their interactions with the therapist.
Yeah.
And if the alliance is strong enough, they can actually examine those thoughts and feelings about the therapist right there in the room, using it as a safe place to test those beliefs.
But therapy, even CBT, isn't always a smooth, straight line upwards, is it?
Oh, definitely not. That would be unrealistic.
The source must address how to handle challenges or roadblocks that come up?
Yes, it does. Problems and difficulties are pretty much expected. They're just seen as more data, more information.
Not signs of failure.
Not at all. So if sessions start feeling unfocused, or maybe a patient seems resistant to trying homework, or gets stuck on a particular issue, the therapist doesn't just, push harder or get frustrated. Instead, they pause. They step back and try to explore the underlying reasons. What dysfunctional thoughts or beliefs might be driving this difficulty right now?
So if someone isn't doing the homework, the question isn't just, why didn't you do it? It's maybe more like, what thoughts went through your mind when you thought about starting the homework? Or what feared consequences came up? Or what might attempting this homework mean about you if you succeeded or if you struggled?
Exactly. It's applying the same cognitive model to the therapy process itself. Understanding the patient's thoughts about the therapy or about the therapist, or maybe about their own ability to change, allows the therapist to integrate those insights back into that conceptualization map we talked about, and then adjust the approach collaboratively. The process is flexible enough to handle these bumps in the road while still staying grounded in the core principles.
Okay. And looking further down the road, the ultimate goal isn't to keep someone in therapy forever, right?
Absolutely not.
The source emphasizes planning for the end of therapy, for termination, pretty much from the beginning.
That's a really key insight of the CBT approach. It is not designed to create lifelong dependence on a therapist.
Okay.
The goal is symptom relief, for sure, getting people feeling better. But just as important, maybe even more important long-term, is equipping the individual with a solid set of skills they can use independently for the rest of their life.
So they essentially become their own therapist.
That's the ideal, yes.
Yeah.
Using that map they've built, applying the skills they've learned.
And how does termination usually work?
Well, it's often a gradual process, not just stopping abruptly, maybe spacing out sessions from weekly to biweekly, then monthly.
Okay.
And the source highlights the value of planning for potential booster sessions after formal therapy ends. Maybe a brief check-in session a few months later or 6 months later.
Just to touch base.
Yeah, to reinforce the skills, maybe troubleshoot any new challenges that have come up, and proactively plan for handling future difficulties. It helps consolidate the learning.
And part of that must be acknowledging that setbacks can happen, right? It doesn't mean the therapy failed.
Oh, that's crucial. Absolutely crucial. The material makes it really clear. Setbacks are normal. They're usually temporary bumps, not a sign that the therapy didn't take, or that the person is somehow incapable.
So what do you do if you feel yourself slipping back?
It's about recognizing the early warning signs. Maybe noticing those old, familiar, automatic thoughts popping up more often, or feeling that pull towards old avoidance behaviors.
Okay.
And then knowing how to re-engage the skills you learned. Pulling out your old thought records, maybe scheduling some behavioral activation, reviewing notes from therapy, or even contacting the therapist for one of those booster sessions if needed.
So it empowers the person.
Exactly. It reinforces their confidence in their own ability to manage their well-being going forward.
You know, this whole deep dive, really guided by the source material, it paints such a clear picture of CBT. It's this journey, really, of collaborative discovery. Moving from understanding the subtle but really powerful influence of our everyday thoughts.
Yeah, those automatic ones.
All the way to systematically examining and potentially reshaping these really deeply held core beliefs.
And ultimately, empowering individuals with tangible skills, tools they can actually use to navigate their own internal world more effectively.
It really comes across as a structured, active process, one that prioritizes equipping you, the listener, with the tools to understand and modify your own thinking and behavior.
That's the core of it.
Yeah.
The emphasis is genuinely on learning practical skills, skills that lead not just to symptom reduction, but to improved functioning overall, giving you more agency, more control in your own life.
And hopefully after this discussion, you feel maybe a bit more informed about how this approach works, and perhaps you're even starting to look at those automatic thoughts that pop into your mind in a slightly different light.
Yeah, maybe with a bit more curiosity. And building on that idea, think back for a second to what the source material said about core beliefs.
Okay. Those deep ones.
Those really fundamental truths you might hold about yourself, like I'm incompetent, or I'm unlovable, or I'm bound to fail.
Right. They feel so absolute.
They feel like undeniable facts, don't they? But the material makes it so clear. These are fundamentally learned interpretations, often formed very early in life based on maybe limited or difficult experiences. They feel like truth.
But they function as beliefs.
Deeply held beliefs, yes.
Yeah.
Not objective reality.
So what does all this really mean then? It kind of leaves us with a pretty powerful question to mull over, doesn't it?
Hmm.
What fundamental truths might you be carrying around about yourself or about the world that maybe, just maybe, aren't immutable facts at all?
Yeah.
But are actually deeply ingrained beliefs that, if you were to hold them up to the light and examine them closely, might just be open to evaluation and potentially even open to change.
Definitely something to ponder until our next deep dive.